If you are taking medication for your blood pressure, your cholesterol, or your mood, and you are also struggling with erectile dysfunction, there is a very good chance those two things are directly connected. Not coincidentally, not indirectly, directly. The pill your doctor prescribed to protect your health may be the exact reason your erections are failing. And the reason most men never find this out is that nobody tells them. Today I'm going to tell you. I'm going to walk you through 3 of the most commonly prescribed medications in America, exactly how each one destroys blood flow and kills erections, and what your options are if you're taking one of them. Stay with me, because if you're on any of these, this video could change everything. I'm Dr. Cross, 18 years treating men's sexual health in clinical practice, and I can tell you from experience, medication-induced erectile dysfunction is one of the most underdiagnosed and undertreated conditions I see. Men come to me after years of struggling, after trying Viagra, after feeling like their body has given up on them. And when I look at their medication list, the answer is right there. It was there the whole time. Their doctor never mentioned it. The pharmacist never mentioned it. And the man sitting in front of me had no idea that the pill he's been taking every morning was quietly dismantling his sex life from the inside. Gentlemen, listen up. This is not rare. This is not a fringe side effect that happens to 1 in 1,000 men. The medications I'm about to describe cause erectile dysfunction in a significant percentage of the men who take them. We're talking about drugs that tens of millions of American men take every single day. If even a fraction of those men are experiencing sexual side effects, and the research shows it's far more than a fraction, we are talking about an enormous silent epidemic that nobody is discussing loudly enough. Let's start with the first category, blood pressure medications, specifically 2 classes, beta blockers and thiazide diuretics. These are among the most prescribed drugs in the United States. Beta blockers work by slowing your heart rate and reducing the force of your heartbeat. That lowers blood pressure. But here's the problem. An erection requires rapid, forceful blood flow into the penile tissue. When you chemically reduce the force of blood flow throughout your entire body, you reduce it everywhere, including where you need it most. Beta blockers also interfere with the nervous system signals that initiate an erection in the first place. The result is a double hit, less blood flow and a blunted arousal signal. Studies have shown that men on beta blockers have significantly higher rates of erectile dysfunction compared to men on other blood pressure treatments. And yet beta blockers remain one of the first-line treatments doctors reach for. Thiazide diuretics work differently. They lower blood pressure by reducing the volume of fluid in your bloodstream. Less fluid means less pressure, but it also means less blood available to fill the erectile chambers. Think about trying to inflate a balloon with half the air you normally use. The mechanism is straightforward. The outcome is predictable. And again, widely prescribed, rarely discussed in the context of sexual function. Here's what most doctors won't tell you. Not all blood pressure medications carry the same risk. ACE inhibitors and ARBs, another class of antihypertensives, have a much better sexual side effect profile. Some research even suggests they may improve erectile function in certain men. If you are on a beta blocker or a thiazide diuretic and you are struggling with ED, this is a conversation worth having with your doctor. You may not need to give up blood pressure control. You may just need a different drug. Now here's where it gets interesting. The second category is antidepressants, specifically SSRIs, selective serotonin reuptake inhibitors. These include some of the most recognized drug names in America: Prozac, Zoloft, Lexapro, Paxil. SSRIs work by increasing serotonin availability in the brain. Serotonin stabilizes mood, but serotonin also suppresses dopamine, and dopamine is the neurotransmitter most closely associated with sexual desire and arousal. When you raise serotonin chronically, you blunt the dopamine response. The result is reduced libido, difficulty achieving arousal, and in many men, direct erectile dysfunction. How common is this? Studies suggest that sexual dysfunction occurs in somewhere between 40 and 60% of men taking SSRIs. Let that number land for a moment. Nearly half to more than half of the men on these medications experience some form of sexual side effect. And yet, when a doctor writes that prescription, how often is the patient warned about this? In my experience, not often enough. I had a patient, let's call him James, 61 years old. James came to me for ED, had been struggling for about 2 years. He was on a beta blocker for blood pressure and had started an SSRI about 2.5 years earlier for anxiety. He had never connected the timeline. I asked him, when exactly did the ED start? He thought about it, said it started maybe 3-4 months after he started the antidepressant. That was not a coincidence. That was pharmacology. We worked with his prescribing physicians. One medication was switched, the other was adjusted. Within 8 weeks, James reported significant improvement, not because we gave him anything new, because we stopped giving his body something that was working against it. Let me break this down for you clearly. The third category is statins, cholesterol-lowering medications. Atorvastatin, rosuvastatin, simvastatin. These are household names. Statins work by inhibiting an enzyme your liver uses to produce cholesterol. Lower cholesterol, lower cardiovascular risk. That part is well established. Here is the part that is less discussed. Cholesterol is the raw material your body uses to manufacture testosterone. When you chemically suppress cholesterol production, you can also suppress testosterone synthesis. Multiple studies have found associations between statin use and lower testosterone levels. And lower testosterone means lower libido, lower arousal, and in many men, direct erectile dysfunction. The relationship is not universal. Not every man on a statin will experience this. But in men who are already on the lower end of normal testosterone, statins can tip the balance. And nobody checks for this. Nobody monitors testosterone when they prescribe a statin. It simply does not happen routinely. Now, I want to be direct with you about something important, because I know what some of you are thinking. I am not telling you to stop taking your medications. I am not telling you that your blood pressure does not matter, or that your cholesterol does not matter, or that your depression does not matter. Those conditions are real, and they need to be managed. What I am telling you is that the specific drug used to manage them matters, and your sexual function matters. Both things can be true at the same time. If a medication is destroying your quality of life in one domain while protecting it in another, that is a legitimate medical conversation to have with your doctor. You have the right to have that conversation. You have the right to ask, is there an alternative that carries less sexual side effect risk? In many cases, the answer is yes. This is backed by real science, not internet nonsense. The research on medication-induced erectile dysfunction is decades old. It is not controversial within the medical literature. The problem is not a lack of evidence. The problem is a lack of conversation. 15-minute appointments do not leave room for nuance. That is why I am here. If you take one thing from this video, make it this. Look at your medication list. If you are on a beta blocker, a thiazide diuretic, an SSRI, or a statin, and you are struggling with erectile dysfunction, do not assume your body is just getting old. Do not assume this is inevitable. Make an appointment with your doctor and ask directly, could my medication be contributing to my ED, and is there an alternative? That question could change everything. James asked it. It changed his life. I have put together a complete protocol that covers everything I walk new patients through in the first 30 days, including how to approach these medication conversations and what to optimize on the lifestyle side while you work with your doctor on the pharmaceutical side. The link is in the description. If this was helpful, hit subscribe. I put out new videos every single day to help you take control of your health. I'm Dr. Cross, and I'll see you in the next one. Before I let you go, I want to address something that comes up constantly in my practice. Men feel embarrassed to bring this up with their doctor. They worry about seeming like they're prioritizing their sex life over their health. I want to dismantle that thinking right now. Sexual function is not a luxury. It is not vanity. It is a core component of quality of life, relationship health, and psychological well-being. Research consistently shows that men with erectile dysfunction have higher rates of depression, anxiety, and relationship dissatisfaction. The impact is real, and it is significant. When your doctor prescribes a medication, their job is to manage your condition with the least possible impact on your overall quality of life. Sexual function is part of that equation. If your doctor dismisses this concern, find a doctor who takes it seriously. You deserve that. There is also a practical reason to pay attention to this beyond the obvious. As I mentioned earlier in this video, erectile dysfunction is one of the earliest signals of cardiovascular disease. It shows up 2 to 3 years before a cardiac event in many men. If your ED is being caused or worsened by medication, you may be masking that signal without addressing the underlying vascular health issue. This is why a comprehensive approach matters. It is not enough to simply switch medications and call it done. You also need to be actively working on your vascular health, your diet, your exercise, your sleep, your stress. The medication conversation is one piece. The lifestyle foundation is the other. They work together. One more thing I want to leave you with. If you have been on one of these medications for years and you have been experiencing ED for years, and you assumed it was just aging, just stress, just bad luck, I want you to hear this clearly. It may not be any of those things. It may be pharmacology, and pharmacology can be changed. You are not stuck. The conversation with your doctor that you have been putting off might be the most important health conversation you have this year. Have it. Bring this information with you if it helps. Print it out if you need to. Your doctor should welcome an informed patient. And if you need a place to start, the protocol I have put together in the description covers exactly how to approach this conversation and what to track as you make changes. The men who get results are the ones who treat their health as a system, not a collection of isolated problems managed by separate prescriptions. Your blood pressure, your cholesterol, your mood, and your sexual function are all connected. When you start seeing them that way, everything changes.